Okay. Now, the topic is salivary gland endoscopy or Sialendoscopy, and for doing this procedure, the goal of the procedure is to leave a physiologically intact gland and to avoid open surgeries. These are not new. Salivary endoscopies have been done for a long time by people using various equipment. There was a group of endoscopes by name microendoscopes originally introduced in engineering and brought in for eustachian tubal endoscopy sometime in the 90s. And they were all used. So there is nothing new. Only thing we should be thankful to two companies of the world, Stars and there is one more German company, I'll tell you the name. There are two German companies who now spearhead this salivary gland endoscopy. No, Olympus had flexible, they are no longer in the picture. Both are German companies, both are rigid and semi-rigid. Now, for treatment of salivary gland, you should know that major salivary glands like parotid and submandibular, we get quite a few patients. Maybe in an average ENT practice, you will get salivary gland stricture, obstruction, inflammation, at least or about 5 to 6 cases a year, minimum, in any type of ENT practice. And these are the patients whom you have to aim your treatment for. You can do many types of investigations. This is one investigation which I have included to say not to do, that is sielogram. It's a very good old investigation where you put a dye into the duct and see where all it goes. But this leads to some problems, especially in the ostium, and it can prevent you from doing a good scopy later. So avoid this sielogram. You can go for CT, which is probably the better one in radiology. MRI is probably not indicated. So CT may be the best in the radiology techniques. And the most important investigation is ultrasound. Ultrasound is the most important because it is non-invasive. You can repeat it any number of times. And most of the doctors, radiologists have probes for thyroid. Some 5 to 7 megahertz, if you have, it's fine. The higher the frequency, the better the resolution of the image. So you can see here how the duct can be visualized. The radiologist has linked two images and formed the ductal pattern, and here there is an ostial stenosis. Here there is an ostial stenosis, this is a duct, this is a gland. This is one more ultrasound which shows the parotid duct, and this also shows some dilatation and pathologies here. You can see the stone here. Please remember, in ultrasound, stone will not be seen like CT scan, a dark white spot. It will be different. It will form only shadow. That is the reason why if two stones are near each other, you will see one stone only in ultrasound. So you can't fault the ultrasoundologist if he tells one stone and you get two stones. Recently I had a patient where there were totally 13 stones and the ultrasound person had counted only some 6 or something. But it's not his fault, it is a limitation of technique. These are situations where some treatment has been attempted on these ducts. This is a parotid where somebody has attempted to open the duct from inside. Now, I want to talk about it at least in a detailed way, so you go with this message very clear. Submandibular salivary duct, it is a long duct. It is quite, it accepts insults. You can open the duct, take out the stone even without endoscope in your OP. I'm sure all of you would have done submandibular calculi excision sometime or sometime in the career. Or the dentists do it. Some dentists are also doing submandibular calculus removal intraorally by just slitting with local anesthesia. Duct is long, it heals, not much stricture forms. Parotid, don't try this. The reason is, as soon as it opens, as soon as it leaves the mouth, it goes very deep. It goes between the muscles into the cheek substance and goes back. So you try to open this parotid duct, you invariably land with more scarring and this parotid duct doesn't like scarring. It is like eustachian tube. Okay, it doesn't like scarring. Don't try to do open surgery of the parotid by, see, I have had patients where plastic surgeons have attempted this one removal, stone removal through the mouth. This happened to a MS orthopedic doctor, and his colleague had done it. This man landed with an osteal stenosis, required a stent. And there is a young girl from a very poor family, and they said they will cure her, and they damage the duct. Now, periodically, we dilate it, we do all sorts of things, and in her case, there is a calculi, but the calculi was outside the gland substance. Remember, a calculi can form within the duct, it can also be outside the duct. There is no rule that all calculi should be inside. Only when it is inside the duct, we all have to go and remove. If it is in the gland, leave it. What are you going to do to a phlebolith in your thyroid? Let's leave it. So unless it's obstructing the flow, there is no need to do anything. So ultrasound is very helpful. If you want to do open surgery intraorally, submandibular stone, if it is large and you can locate, and you can put a transfixing suture behind the stone to prevent it migrating back, and you have some microscope, it will be very good, you can do it. But parotid, be very careful. This is again one more case of submandibular calculi. You can see the calculi here, and here after the stenosis in the ostium, dilatation of the duct. So these are cases of atrophic glands with fistula leading to the skin. These are not physiological glands. Salivary endoscopy is meant only when gland is alive and it is open into the mouth and producing saliva. A gland that is dead, for example, after radiation or after a very long standing infection of stone and stricture and so forth, if the gland is dead and a mass of fibrosis, probably one can just leave it alone unless it's going on recurring infection, in which case you do open surgery. This is a hilar stone. Forgive me to introduce this term without a picture, but I'll show you the picture very soon. This is the picture. Now, before I send a patient, if any of you want to copy one slide from this presentation, copy this slide, because this is a picture which you can draw in a paper and send it to the radiologist to show the location of the stone. This is the orifice, sublingual gland, duct, hilum, and this is the gland. This is the submandibular parotid. Radiologists write one page of report, but you ask them just to mark it where the stone is, what the size is. This will be much more accurate than one page of written information. So all the cases now, including some of my colleagues, have taken up this kind of diagrams, which we send as a blank, and the radiologist just draws where the stone is and sends back. This is more useful for practice. You will know where it is. For example, if the stone is somewhere in this gland here, salivary endoscopy just cannot reach. So you know nothing is going to be done. Mylohyoid muscle also is marked. Above the mylohyoid muscle, one can reach with the scope. Beyond that, you can't reach. You have to use some special techniques for it. So these are the indications. Endoscopy is used for obstructions. Obstructions in the gland could be due to stone or could be due to stricture. And one more thing is recurrent sialidinitis of childhood, what we call recurrent juvenile sialidinitis. A similar presentation in adult when you have papillary carcinoma thyroid and you subject them to iodine 131 for treatment of thyroid carcinoma, then all the iodine is excreted through the salivary gland and they go for parotitis. So you have to treat them very aggressively. Any of your clients is having a papillary carcinoma, going for iodine 131 treatment, kindly treat them conservatively for the parotid before it becomes chronic parotitis. Because once it becomes chronic parotitis, it's difficult. One has to do repeated scopies and so on and so forth. So these are the basic points about sialendoscopy, and let me talk about some of the scopes. After all these things have come, flexible was made by Olympus. rigid, original. Now it's all semi-rigid. It is made of, if you see the product literature, in one model they will put nitinol, in another they will put semi-rigid. It is all business methods to fool you. All are nitinol, all are semi-rigid. There is nothing like our nasal endoscope which is made of steel which can't bend. All salivary endoscopes are semi-rigid. Some new designs, one can even bend the tip a little bit. And it comes pre-bent, called Marshall's. So amongst the semi-rigid scopes, if you want to buy a scope for yourself, for your practice, I believe this will be the good one, because the modular scope has more strength, inherent more metal, and less chances of breakage. These are the duct dimensions of your submandibular and parotid duct. You must see that this is only some 1.4 millimeter when it is dilated. That is the submandibular duct, and the Wharton is 1.5. And you can use these wire baskets for less than 4 mm stone and 3 mm stones also. Now, any of you want to learn about salivary endoscopy, you must become friendly to a urologist, because all the techniques of salivary endoscopy which I am using, I basically learned from urologists, because they are the people who have been using baskets, dilators, guide wire, through the guide wire introduce a stent. These are all very common for them. So you talk to them more often, you learn these techniques from them, and you can proceed. So this is a treatment room set up in a university hospital in Germany, in Nuremberg. That place is called Erlangen, and this is it's actually one room. I made 2 photographs to link them. So here you have the microscope for seeing the duct and the orifice and dilating. I believe you need an operating microscope to see the duct orifice, dilate it, and introduce a scope. This is an ultrasound which in most of our Indian setup it's held by a radiologist. If possible, you can go for a few cases and learn it. And this big machine here, it is called a lithotripter, called mini lith. Unfortunately, it is not being made anymore for salivary endoscopy. The company found that there are too few buyers, so they stopped making it. So we don't have lithotripters of German make. We have some Israeli manufacturer which will only shake the stones, won't powder it. So probably it's not worth. You have to learn how to do fragmenting of stones without lithotripter. And some time back, I think I had used it in social media, how we had linked a hand drill to a autology drill and drilled a stone through and through using a modular salivary endoscope. So some types of technical innovations you have to do to get out of tricky situations like big stones that refuse to move, because lithotripter is no longer there. Though it is there in all the literature. All the books you read now, you will talk about lithotripter, but it is not there. So this is how we are doing. Most important to know that this endoscope has a flexible portion and a rigid portion. The flexible portion is connected to the camera, which is connected to the scope, and this portion is kept into a sort of a well stabilized OT table with a cloth, and the telescope is sort of clipped to the cloth so that it won't fall down when you are doing. The company claims 200 scopies for every salivary endoscope, but in India, if you are going to do 200 scopies and then throw away scopes, we'll have to charge too much for our patients, and we have to be careful in handling and prevent them. And one of the simple ways, even for your nasal endoscopies, to make them live long, use them in patients, use them in saline. In the end of surgery, use distilled water to clean all the deep recesses, because that is where the salt goes and precipitates, eats away the metal. So I keep a distilled water, what we give for batteries, and flush them with a syringe. Finally, air flush it so that all the distilled water also goes out. So all your instruments use distilled water to prevent damage, especially endoscopes where they couple it to your fiber optic cable. That is where rust starts, and the rust becomes, you won't even know. but inside the rust will go into your fiber and the light will become little yellowish. Soon in your video camera, you will have to white balance more. In one telescope, it will be yellow color, another telescope will be white. That means your telescope is getting rusted in the where you connect the fiber optic cable. Remove that adapter, clean it well for all endoscopes where water is going to be used. Now, I told you about Sialendoscopy technique. Basically, it is done under local anesthesia, and this is the solution we use. We irrigate with a 22 size Venflon into the duct. We don't inject as a matter of routine. Sometimes, if in difficult patients, we may inject, but not as a matter of routine. I told you already, microscope is more easy to find the duct. Between the two ducts, parotid and submandibular, if you are going to do cases by yourself, start with submandibular because the duct is long, it's more forgiving. And only thing, it is more difficult to enter. Parotid duct is easy to enter, but more difficult to manipulate. You imagine your patient of nasal endoscopy floating in water, and you are putting an endoscope into the nose when he is freely floating, and you want to go here and there. Wherever you twist, the body will twist. The scope won't go. Like you want to go into the sphenoid, you just go in. But in salivary endoscopy, the whole gland is soft. There is nothing rigid. So it is like your nose floating in water. So you have to have that gentle feel, and all the time, just like gastroenterologists, you know why gastroenterologists never touch cricopharynx for biopsies? Any of you thought of it? They'll do biopsies anytime below cricopharynx. But cricopharynx, they can't. It's a blind area for them because your gastroendoscope requires air to dilate the viscera before it can see. And cricopharynx, it is just after entering cricopharynx only it will dilate. So that is why in gastroenterology, cricopharynx is a blind area. Same way, in salivary endoscopy, ostium is a blind area. As soon as you go in, you start irrigating with a lot of water. It's actually underwater. Your salivary endoscopy is done underwater. That's why there is no fogging, but there is so much debris and other things coming and clouding. But you have to do everything underwater. Only water dilates the duct and allows you to see. If you don't irrigate with water, you lose vision. Okay? So these are the endoscopes. This is a compact. I believe this is probably the best for a beginner. And these modular scopes are very nice, but this is more easier to use, more robust. One channel for irrigation, one channel for manipulation, and through this channel only I am using this hand drill, mate it with an electric drill, and you can drill even larger stones with it. So these are the baskets for wire retrieval. You must remember the word 2F. 2 French is the size you need for salivary endoscopy, around 1.2 mm. So these are made by a company called Cook, which is again a urology equipment manufacturer. So this is the hand drill. These are the catheters, the balloons. We use small balloons to dilate strictures. This is a ear surgery forceps, and these two are salivary forceps, just as a comparison. I'm very proud to say this salivary stent, it's made in our country. Till recently it was imported. Now there is an excellent man who is doing it in Bangalore. Again, he does it for other specialties, and they are really good. You have these guide wires through which you can use these bougies. So this is a little about technique, how to do, when to do, and so forth. Now let us come to the commonest cause for salivary obstruction, that is stones. This is the pathophysiology. I'll skip over the points which are theory and go only for practical because of the time. These are the duct dimensions. Again, I want to emphasize the maximum duct dimension is only 1.4 mm. It's very small. So these are large stones of the submandibular duct, which sometimes, suddenly all stones, you will get only 1 centimeter stone, 1.5 centimeter stone from the hilum. So in such cases, I do something called a double approach, but I'll just show you video of how a simple salivary endoscope is used, how it is seen. This is a forceps going in. These are fibrinous threads that are floating inside the duct, and the fibrinous threads are removed. Otherwise it will cloud and prevent us from seeing. The movement is caused by the water. Inflamed duct is white and the normal duct is pink. These kind of fibrinous exudates are part of inflammation. These are dilated ducts at the end of which you can see. I'll show you some other better videos. It's a patient from New Delhi who was offered open surgery there, who wanted to get it done by scopy, and this is by using a basket. The basket itself is a dilator. If you open the basket within the stricture, basket itself becomes like a dilator. The duct is so thin and fine. You can see the stone there. The basket is going. I think the full video is not here. This is a patient who had an unindicated open surgery on the parotid duct. We had to really struggle to recannulate the duct, take out the stone, put a stent, and to top it all, the family just can't afford any payment. So sometimes it's very difficult to do these kind of things in non-paying patients, but someone has to do. Being an 18-year-old girl, somebody has to help her, so we did that. So now that problem has been settled, but it took almost 3 times scopy to do this. You can see the stone there. I'm sorry the images are like this, but in salivary endoscopy you don't get better images because they are basically flexible scopes with a rigid tube in the tip. This is actually dilating the stricture with forceps. You go through the stricture with closed forceps, open it and twist it. So that's a way of dilating the stricture. This is another patient with a, you can see the fibrinous exudates all coming out. Sometimes stones will get buried into the duct substance. We have to pull it out, hook it out, and then basket it. This is a duct. This is a typical appearance of a duct. This is a branching, secondary branching of the duct. To get into these branches only, we have to use guide wires at times. So all these are dilated ducts caused by proximal stenosis, and sometimes you get only stricture with no stones. So these are the cases of the parotid. You can see the duct has been compressed from outside. And that's a stone sitting on the side. Sometimes you are asked to dislodge it before you can take it out. These are the other branches which are healthy. Fibrinous exudate, which is hallmark of inflammation. I am using the basket. You have 2 types of baskets, tipless basket and tipped basket. And tipless is used when you can't go beyond the stone, and tipped is used when you can go through the stone from a gap and then grab it from the back. This is dislodging a stone with a forceps. See, the whole scope and the forceps has to come out. So here also you can see I am putting a basket and the stone is grasped, and together with the scope the stone has to be taken out. And near the orifice we become blind because of the problem I told you. Now this grasping a peanut from the bronchus, you know, you have to hold the peanut, and in a pediatric bronchoscope you pull the peanut through the scope, what happens? The peanut is going to fall down. So the teaching is you hold it nicely and take it out as a unit. The same teaching in salivary endoscopy also. You cannot withdraw a basket through the scope holding a stone, because this endoscope will have only 1 mm channel and the stone is 4 mm. So it gets stopped at the tip of the scope. The whole scope and stone has to be taken out. So these are the treatments which I told you. Simple salivary endoscopy is ideal for stones less than 6 mm. This is one take home point. Any of your patients have less than 6 mm size stones, then simple salivary endoscopy, anybody can do it. More than 6 mm, you need people with special equipment or special skills. So these are the sizes that are possible for Stenson and Wharton's duct. Combined approach is possible, but it should be avoided in parotid. So you can also use laser, but it is phenomenally slow. It takes hours to drill through this one with a laser. That is why I started using mechanical drill. So endoscopic success rate is good, but it is not so high when you are starting your career. So this is when you have a stone, a huge stone sitting in the hilum, and you can't pull it out through the duct. The stone is around 1.5 centimeters. The duct is here, and this is a lingual nerve. Lingual nerve is marked here. So I'll show you how it is done. Basically, we locate the stone with the sialendoscope and use a nasal endoscope and make a incision in the near the gingivobuccal sulcus. Gingivobuccal sulcus near the last molar teeth. I'll show you the video, which will be self-explanatory. So it is basically a combined technique. This is the huge stone seen through the endoscope with the salivary, and I'm trying to hold it with the basket. It's not working, it's too big. So we go for the nasal endoscope, make an incision, take out all the venae committantes which accompany the lingual nerve, and you can see the submandibular gland below. You use the Burkett's long artery forceps of tonsillectomy for this kind of dissection, but all dissection to be done under vision. Here you can see the lingual nerve. Here you can see the submandibular duct with the stone inside, which I am just cutting and opening. Can you see this? This is the lingual nerve and this is the submandibular duct. After this is done, we put a stent so that the duct doesn't go for a obstruction. This is another case. Like this, several cases have been done, all megastones. These were the initial days when even megastones I tried to drill my way through. It doesn't work. Neither can you basket it. The best is to go for double approach. This is a double approach. You can see the dilated duct giving up the secretion. Once the mucus secretion comes, I know I am behind the obstruction. This is a double approach for large submandibular stone. Here the stone is getting taken out. This is the incision, and this is a large stone. There is one more patient. Is another patient with large calculi. So this is just a pictorial representation of the lingual nerve. Why I am putting this lingual nerve 2-3 times I am telling lingual nerve, because injury to hypoglossal nerve may be forgiven by the nature, because somehow people know how to eat and talk with one hypoglossal nerve. But you take away one lingual nerve, lifelong tongue bite will remain. So lingual nerve as such is more important to patient than hypoglossal. So always avoid damage to lingual nerve. See it before you do these things. This again, you can see immediate better in video quality. These are the new endoscopic cameras and they give a much better resolution. So this is the incision which I told you next to the last molar teeth near the gingivolabial sulcus. Okay. So this is a new technique which avoids external operation for even large stones. Basically, one can avoid the large external incisions and take away the stone and save the gland also. So these are the advantages of the double approach. Now this is about stones. Now let us talk something about ductal stenosis of stricture. If you look carefully, the number of people with stones and the number of people with stricture, if 3 people are coming with stones, there will be at least 2 people with stricture, where ultrasound will not show a stone, but stricture will be there. But stricture also has to be treated. If you don't treat stricture, again they will go for recurrent sialadenitis. So to treat a stricture, you basically dilate it. If you have salivary endoscope, you can dilate it with the mechanisms I told you. You don't have salivary endoscope, you can even use a Venflon, a 22 size Venflon, what we use for our anesthesia. You can anesthetize with just 2 ml of 4%. Don't inject more than 2 ml for a salivary gland. That will anesthetize the duct. Then you forcibly infiltrate hydrocortisone with saline solution. That is hydrostatic dilatation. Even without mechanical dilatation, it works. It especially works for juvenile parotitis and also this iodine 131 parotitis. These are now treatment protocols which are done by junior doctors in our hospital. Patients who come with these kind of things, in fact, salivary endoscopy, post-op care, just like our endoscopic cleaning, they do this kind of injecting into the duct to dilate it and to clean it. So if you see in stenosis, the shorter stenosis is better, the shorter membrane is ideal, etc. Seldinger's technique is a time-honored technique where you pass a guide wire and then you dilate. So these are the patients. I think I'll show you a stricture. This is a patient who has a large who has a stone being retrieved by a basket. Okay. Sometimes the stone rolls like a football game. Because the water is going with pressure, it will try to move away from you. The basket is an excellent tool. Once it catches, it is like that grip will never go. You can always take it out. Sorry, this is here there is a stricture, and now I have a situation where the stone is caught behind the stricture and the basket is not pulling it out. Okay, these are situations which can lead to a problem called basket lock. I'll show you how to deal with it after some time. This is a juvenile recurrent parotitis, which I'm sure you will be getting patients, and this is the technique for taking care of it. Even without salivary endoscopy, you can treat this condition so that the recurrence doesn't come. So, this alone I will not suggest you to do. This is Naheli is an Israeli dentist. He had been to our hospital for running a workshop 2 years back, and he has his own excellent techniques. Like he can take out the front stricture of a submandibular duct, pull the rest of the duct and suture it intraoral. So the stricture part is sort of removed, totally removed, and the rest of the duct becomes the actual duct draining into the mouth. So nice to know that even dentists are doing this. I think in Bangalore also there is a dentist who are doing it. If you guys are not taking up these kind of techniques, this will all go to dentistry only in future. So all the youngsters better start doing these things. So these are what are the bad effects? Temporary swelling. Generally, we don't even admit, they come in the morning and they leave in the evening. It's a daycare procedure. Sometimes you have this basket blockage and things like that, but there is no major complication. In double approach, if you cut the lingual nerve, it's a problem. So this is a case where stone was caught in a basket, we pulled out. At one point, the stone stopped coming, it doesn't move forward. Then you pull forcibly, what will happen is, the whole thing will be pulled out, but the duct will be severed. It will be like a, what do you call that? In certain road traffic accident, you have a tracheal dislocation injury, like that you will get in the salivary duct. So when you have a lock-up basket like this, you go behind it, cut it, release the basket through it, open the basket, take out the stone and withdraw. So sometimes these kind of minor complications happen, but it can be overcome. So I think I finished my talk in that 30 minutes. And of course, I need not tell who is this, my mentor, my guru. And this is the person who owns the Stores company. She is Madam Stores. And we had a chance to take a lucky picture in Nuremberg. Thank you very much.